Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to the Going Antiviral podcast. Today, March 3rd, 2024, we're at the Conference on Retroviruses and Opportunistic Infections, and we're speaking to Dr. Jordan Lake, Associate Professor of Medicine at the McGovern School of Medicine in Houston, Texas. Jordan, welcome.
Well, thank you for having me.
Well, we've got a lot to talk about, and I think I'd like to focus on fatty liver disease, whatever we're calling it these days, NAFLD or MAFLD or something like that for metabolic non-alcoholic fatty liver disease. But one of the things that we've noticed, maybe start with this, is what do you see in the population of people with HIV versus controls who are not HIV infected who have non-alcoholic fatty liver disease?
That's a good question. So most of the data to date has been observational studies, and a lot of it's been cross-sectional, but most studies would show a slightly higher prevalence of fatty liver disease in people living with HIV compared to the general population. It is an age-related disease, so once you get over 40, your risk goes up no matter what, and then with certain comorbidities like diabetes and high cholesterol, other things that are common in people with HIV also increase your risk. So some of that increased risk may be from other comorbid diseases, but we know HIV itself also, the virus is in the liver and cells in the liver can be infected, and there are direct effects of the virus on the liver. So that is another area that's really still an evolving area, and we don't understand how the virus itself exactly may contribute to fatty liver disease, but there's some unique insights, and so hopefully we'll start learning that more. What we do know from biopsies is that people with HIV have a more aggressive form of steatohepatitis. So once you get that inflammation going, it's more aggressive, and people progress faster to fibrosis or progressive liver disease, which then has the risk for cirrhosis and hepatocellular carcinoma.
So this is a chicken and egg question, but is it the fat in the liver that causes the inflammation, or is it inflammation that causes fat in the liver?
It could be both. It could be both. So you're right, it's a chicken and egg question. So it may be some of the inflammation from either gut barrier breach and just the sheer irritation of the liver, seeing those microbial products all the time. It could be inflammation from crosstalk with the fat that's nearby. But also, once you start accumulating fat, it's really similar to me to eating too much. You know, the cell wall's like your belt. And when your belt gets too tight, the cell gets unhappy. So when the cells are unhappy, they start becoming hypoxic from having too much fat in them. They send out all these distress signals that sort of ramps up inflammation locally, and then eventually it spills over into the circulation.
So you actually have several abstracts here at this CROI meeting, and one of them is on the population you're talking about. What I noticed, if I read it right, was that it was men who had a little bit more steatohepatitis than women in the study. Is that accurate?
The NASH, the non-alcoholic steatohepatitis clinical research network, that's one of the abstracts, and those are biopsies from people without HIV and then matched groups of people with HIV. And in that group, it did look like there may have been a little bit more steatohepatitis in the men, but it's a large number of biopsies, but it's still a relatively small study, and I think that's going to play out.
So the first time I ever encountered fatty liver disease in a patient was back in the days of AZT. Mm-hmm. And we had a person who came in with lactic acidosis syndrome. and they ended up dying from it. And we did an autopsy, and the liver was almost 95% fat. And that almost certainly was from toxicity of nucleoside therapy. D4T was very prone to do this. D4T and DDI together, wicked combination, bad for the liver long term. But the newer drugs, tenofovir in particular, and the FTC-3TC group, don't seem to be associated with as much fatty liver. But in your studies, can you tease out how much any nucleoside may be contributing over a long period of time of exposure to maybe more of a tendency to have fatty liver disease?
That's a good question. From the observational data that exists so far, it doesn't really look like any of the currently favored agents really have direct hepatotoxicity the way the thymidine analogs are. And people who are exposed to D4T don't seem to have residual hepatic steatosis from D4T per se, but they, in folks that experienced a lot of lipoatrophy and then now have fibrosis of their subcutaneous fat and are sort of being forced to store fat in their liver because they can't store it somewhere else, it may be an indirect side effect of some of that thymidine analog exposure previously. And then something we don't totally understand with the integrase inhibitors is they get taken up into fat very well, and NRTIs do not. So how are they contributing or not contributing? Does that matter? The actual penetration of the ART into fatty spaces, that's something that still needs to be worked out.
So there's a whole new focus on the treatment of fatty liver disease. Your group, others have nicely described the phenomena happening more and more, especially as people get older, as you said, living with HIV. But the therapeutic arena is starting to wake up and develop some new approaches, and you have another abstract here on the use of semaglutide, which we know about as a weight loss drug, we know about as a treatment for type 2 diabetes, and it seems to be the rage, even among some people who don't really need it, because they just want to look a little better at the beach, not a great use of the drug. But your study was looking at, it was an ACTG study looking at the use of semaglutide in people with fatty liver disease using MRI assessments to see how things change. So maybe just set the stage for what that study is about and what you all did.
Sure. So now 8 years ago in 2016, before semaglutide was even on the market, we really had the idea that this class of agents, so it's a glucagon-like peptide 1 receptor agonist, may be beneficial for treatment of metabolic disease. And there were other agents in that group on the market at the time, like liraglutide. And we designed the study really because we thought that the mechanism of action and how it works should reduce liver fat. And so we didn't go into it to be a weight loss study per se, although that is the number one treatment for fatty liver disease is weight loss, and semaglutide does make you lose weight. So in a way, it's also a pharmacologic weight loss study. But it was really designed, can we prevent or reverse fatty liver disease? And unlike a lot of studies that focus on NASH or more advanced liver disease, myself and Christine Erlandson and Fred Sattler, who proposed the initial work, we wanted to think of it more as prevention. Can you intervene early when somebody has too much fat in their liver, but they haven't yet progressed down the liver disease angle, and they don't yet have a contribution of their fatty liver disease to their cardiovascular risk? Can you get in there early, reduce the liver fat, prevent insulin resistance, prevent hypertriglyceridemia, reduce overall cardiometabolic risk? That was our goal. And so after working its way through the ACTG, we enrolled 51 people living with HIV who also had increased waist circumference and some measure of insulin glucose intolerance. You could have prediabetes, you could just have insulin resistance without abnormal glucose, or you could have abnormal fasting glucose, but still be maintaining your insulin sensitivity. And we picked those parameters because those are the folks who are most likely to have fatty liver disease. And everybody underwent MRI, and if you had more than 5% of your liver volume by MRI composed of fat, that's meeting the definition for fatty liver disease, and so those folks went into the study. Everybody got drugged. This was not a placebo-controlled trial. All 50 people went on what you would now consider to be a low dose of semaglutide, only 1 milligram weekly. That's a dose that's approved for diabetes, and that's because that was what was on the market at the time. The weight loss dose is actually 2.4 milligrams a week. But after 6 months of 1 milligram weekly, people lost on average about 17 pounds. So that's pretty fast, but it's still within the realm of what's considered healthy weight loss, which would be 1 to 2 pounds a week. So we feel like we were inducing pharmacologic weight loss, but safely. And we really did see dramatic reductions in liver fat. About a third of people, or 30%, around 30%, actually had complete resolution of their fatty liver disease, which was nice to see. And a large percent had at least a 30% reduction, and that in the general population literature of folks without HIV is what's been shown to correlate with actual biopsy improvements and improvement in actual liver disease specifically.
Have you ever seen a result like that with any other intervention for fatty liver disease? No.
I mean, now that this is sort of coming out in parallel to some of the NASH studies with semaglutide, again, in people without HIV, the amount of reduction you're seeing is pretty similar. But historically, people with HIV are excluded from all NASH trials. So we don't know, if this would be, if other therapies would have had a similar effect or not. This is really one of the first trials specifically for people with HIV. There was also one study in San Diego that was totally negative. It was obeticholic acid, I believe. And so this is sort of the first successful therapy in terms of a clinical trial focused on people with HIV that we know.
So is it at 51 patients, pretty dramatic effect. Is it ready for prime time?
Well, considering how popular it is on the market, I think people will be eager to use it. But I don't think in the hepatology world they're jumping into putting everybody on this unless you already meet criteria for needing it for weight loss or diabetes. I don't think they're jumping into using it as a standalone therapy yet. We still have a lot to learn about this class of drugs, but I think the effect size was certainly impressive, and it was impressive at a relatively low dose. And that those numbers that I gave you also include non-responders, because about 20% of people don't even respond to semaglutide, and no one knows why those folks don't respond. But if you didn't lose weight, also your liver fat didn't go down, and that's what you see. So in people who had a response, sort of similar to what you saw with tesamorelin or Grifta, if you had a response, the benefit to your liver was even greater. So
if I'm just thinking about now the clinicians in practice, we have a lot of weight gain, especially with integrase inhibitors, use of TAF, which is very popular together. Weight gain is almost universal. I think we can assume that several of those folks are starting to go down the path of fatty liver disease. Is there any kind of routine assessment that you think we're at a place that we should start doing this in a clinic? I mean, whether we use elastography at the bedside or something, which we all did back in the hepatitis C days for clinical trials and ultimately for staging. But the CAP assessment that comes with the more modern elastography equipment, what do you think? Where do you think we're going to be going with this in a clinical space?
It'd be really nice to see routine screening for fatty liver disease with people with HIV. It's in the European guidelines already, but it hasn't made it to our guidelines here in the United States yet. For certain populations that are at higher risk. They're not recommending in the European guidelines, they don't recommend screening everyone. And for most, young, healthy 25-year-olds who are very active, I wouldn't necessarily recommend screening them. But I think as providers, that patient that is likely to be at risk. They have diabetes, their lipids are out of control, they're overweight. Those are the people who you would want to screen. And now that transient elastography has, a lot more people have access to it, that's an easy way to screen. Ultrasound is an easy way to screen. There are some non-invasive blood tests that are not perfect, but that you could also think about screening with. It's definitely something similar to smoking cessation that we could be better about identifying as a problem. And what I tell patients is whether or not we have a treatment for your fatty liver disease right now, you need to know about it because it increases your heart attack and stroke risk. And then, people are interested in it when they hear that.
So pulling back to a broader view with treatments, so we have the GLP-1 agonist available. Are there other drugs that you're excited about in terms of treating fatty liver disease of different sorts that are coming along?
There is a drug, I'm going to mispronounce it, resmetirom. I think it's a thyroid hormone receptor agonist. It's really moving quickly in the NASH trials towards an FDA approval. It's in phase 3 now, but it's sort of the most promising of all these drugs that are candidates. One thing that is a big problem is, yes, you could go on semaglutide and you can lose a lot of liver fat and lose a lot of weight, but as soon as you stop, you start gaining weight back. So we need a maintenance plan for people. Similar to if you were going to lose weight, you need a maintenance plan. You don't want to go through all of that, especially some people have pretty bad side effects from these drugs and they're willing to tolerate them for short periods of time to get their weight down, but it's not something you would want to tolerate for your entire life. Right now, that's what the drug companies are saying is, well, you just have to take this for your entire life because we don't have an option. So I think that's sort of the next phase. Or at least for me, I would like to see these as agents that could be used for induction to help out some folks that need it. But then once you've done your induction, you have some sort of maintenance strategy with some other agent or just with lifestyle.
And with this thyroid receptor agonist medication, mechanism that you can imagine why it might work for fatty liver disease? I'm trying to put it together. So I'm not trying to put you on the spot. I'm just trying to comprehend.
I wish I'd buffed up on it before we came to this because I don't feel like I could speak about it right now. It's one of those drugs that it looks like it will have multiple metabolic benefits as well.
And I guess just to broaden it out, I think that this semaglutide is being touted as the great cure for almost everything. There's an old Frank Zappa song that said it'll cure your asthma too. And that was Cosmic Debris. But I'm just wondering, when does it end? Because you're right, it's a huge industry. You see the obnoxious advertisements on TV and these jingles that can't get out of your head. I'm sorry if I just put it there for you, but
Yes.
But they do work for what they're proposed to do. And you're right, they do have, as the GLP-1 agonists have side effects, and some very serious ones, but they're uncommon. And I think the biggest strain is what you alluded to. Once people have had success, getting them off of the medication is challenging, and along the way they can have muscle mass loss and
Yes.
some other things as the weight falls off. So I guess we'll just have to go through that. In your view, now that this ACTG study is done, what do you propose to do next? What would be the types of studies that you would want to go for?
I've been thinking about maintenance strategies and what those could look like, but also the lean mass loss for me is a big deal. If we know that people with HIV lose lean mass anyway at a greater rate than expected for age, and in some groups seem to gain fat at a greater rate than expected for age, others seem to kind of be usual age expected weight gain, but all of us are gaining fat and losing muscle as we age. For people that are already pre-frail or who are already frail, is that going to become a safety issue to lose lean mass? And if you stay on these drugs for long periods of time, do you keep losing lean mass? We don't really know that. So trying to prevent lean mass loss is something I think that you would want to do anyway. You always lose lean mass when you do weight loss interventions because you're losing, you're not doing something that can just isolate losing fat. But will this be different for people with HIV? Will the lean mass loss effects be greater? I think that's something we need to see, and I would like to just find a way to prevent lean mass loss.
It seems like, in addition to what you just said, that since your study was not placebo-controlled, it might be worth at least a short period of time where it is placebo-controlled just to see the relative degree. I think you can more or less just assume that what the outcome you saw was due to the intervention, but that would be nice to document. Work on the maintenance question. Also, I was thinking as you were talking about these, like semaglutide, work better if they're attached to an exercise program, and that maybe some dosed exercise or dosed physical activity, I think is becoming scientifically plausible and doable to maintain lean body mass as an intervention. I think that's something we could do, and maybe that would help if people really adopt more physical activity. It might make it easier to come off of the medications and not have rebound weight gain or liver fat.
That would be the hope.
That would be the hope. Anything else that from your work that we'd like to point out before we close?
No, I just thank you for having me. I love to talk about fatty liver disease. I mean, I think it's something we're really going to learn a lot more about in the next few years. We're going to learn a lot more about these GLP-1 receptor agonists too, and the best way to use them. And I think the field is opening up a little bit for inclusion of people living with HIV in these fatty liver disease trials, and that's nice to see. I hope it continues to open up so we can really get some data, because as we learn what these virus-specific effects may be that we talked about at the beginning, there may need to be slight adjustments in how we treat fatty liver disease in people with HIV. Or maybe they're not, maybe we don't need those adjustments. That's something we'll have to learn.
Well, as a dilettante myself in liver disease, which I've had the joy of watching you present at multiple conferences going back a while, the discussion about fatty liver disease has always been bubbling without much intervention. So it's kind of cool to watch us go to something that has a pretty obvious effect, and fine-tuning it, understanding it better, knowing how to set up the maintenance is a real exciting challenge. And so it's nice to see the field progressing, and it's especially nice to see you right in the heart of it, making all this work.
Thank you.
So thanks for being with us, and
My pleasure.
Look forward to seeing you at the conference.
Definitely.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.